Okay, good evening, everyone, and thank you, Dr. Barnaby, for the introduction. I'm going to be talking about SLT after cataract extraction and MIGS in patients with glaucoma. Glaucoma is the leading cause of irreversible blindness in the world, with an estimated global burden of over 64 million people that is projected to increase to 111 million by 2040. Currently, the only modifiable risk factor for glaucoma is intraocular pressure, and lowering intraocular pressure is the mainstay of treatment to date. The age-related enlarging of the lens is the most identifiable cause of glaucoma. You can see here with age, the diameter of the lens stays the same, but the lens thickness increases with age. Both lens size and IOP increase with age. The mean normal intraocular pressure is 15. The mean intraocular pressure in untreated glaucoma is 18, not 21. So in people with pressures of 18 or higher, it's very important to do gonioscopy. They also often show increased pigmentation. You can see increased pigmentation in the superior angle, but more so in the inferior angle, indicating pigment liberation from the enlarged lens rubbing up against the iris. Also, you can see narrowing of the angle and obstruction of the trabecular meshwork, leading to angle closure as well. There are exceptions to this based on corneal thickness and corneal hysteresis, but at pressures over 15 overall, you don't really get visual field progression. As the pressure increases and corneal hysteresis decreases, you'll have increased progression of visual field deterioration that can occur. In the LIGHT trial, the 6-year data, SLT did better than eye drops for drop-free disease control. 70% of patients that underwent SLT were drop-free at 60 years. Both eye drop and SLT patients, however, did have progression of glaucoma that could occur. The SLT patients did much better than the eye drop patients, but both groups did have some progression. The eye drop patients progressed at 26.8%, SLT patients only 19.7%. And then the eye drop group had more disease progression. The need for more trabeculectomies, nearly twice as much at 5.6% compared to 2.4%, and a greater need for cataract surgery, 92 eyes compared to 59 eyes, nearly twice as much. So what else happens over age 50? At age 50, you can see that the prevalence of cataract starts to increase in addition to increasing the thickness and size of the lens. And you can see here also glaucoma starts to increase. The prevalence of glaucoma increases in all continents, in Asia, Africa, Europe, North America, Latin America, and the Caribbean, and in all ethnic groups, the European ancestry, African ancestry, Hispanic, and Asian. The highest groups tend to be in Latin America and the Caribbean and Africa, and the African ancestry, because both parts of those worlds have the least access to cataract surgery. And when you're looking at these patients, when you look at them clinically, and you look at the lens, if you see pigment on the lens annuals on a lens like this, be very suspicious of pigment liberation taking place in large lens in the eye, contributing to elevated intraocular pressure and possibly glaucoma. This is a video here of Schlemm's canal and the trabecular meshwork. And you can see the normal dynamic activity that occurs with the cardiac cycle. With the cardiac cycle, you have a pumping outflow of aqueous through the trabecular meshwork and the Schlemm's canal. We want to preserve that anatomy. Now, what happens during the thickening of the lens that occurs with aging and accommodation? Here you can see with accommodation, you have posterior bowing of the iris, increased thickness of the lens that occur during accommodation, increased iridozonular contact that leads to increased pigment liberation that can block the trabecular meshwork, okay? And what you will see with aging in these patients, you'll see increased pigmentation of the trabecular meshwork that can occur, that can lead to lowering of the intraocular pressure. And if you look at the iris here, the iris is flat. It's not concave like in pigmentary glaucoma. And this angle is open. You can see pigment on the zonules over here as well. And what happens as glaucoma tends to get worse? You have increased thickening of the trabecular meshwork, decreased contractility of Schlemm's canal. This is a more mild form of glaucoma. And more advanced glaucoma, you have worsening thickening of the trabecular meshwork and narrowing of Schlemm's canal as well. So we have to rethink our approach to glaucoma. And my approach to glaucoma has really evolved to a new surgical algorithm. With early cataract surgery, when you take the cataract out, you can see the angle opens up here and you eliminate the iridolenticular contact that's present there. When you place a thinner, smaller intraocular lens, there's no longer any iris lens rubbing or iridozonular rubbing, and the angle is much more open. And cataract surgery alone can lower the intraocular pressure from 13 to 73%. And cataract surgery has been shown to be more effective in angle closure than laser iridotomy. And you can see here the incidence of angle closure glaucoma is declining in areas of the world, and this is from Taiwan and England, that have increased access to phacoemulsification and cataract surgery as well. And so in addition to doing earlier cataract surgery, in patients with glaucoma, I like to do stents. This is a patient with a hydrous stent, and you have scaffolding of Schlemm's canal to keep the canal open and bypass that pigmented obstruction of the trabecular meshwork to help lower the intraocular pressure. And recent 5-year data, post-hoc visual field, looking at the visual field of these patients at 5 years out, showed that patients who had cataract surgery and hydrous compared to cataract surgery alone had a 47% decrease in visual field progression with a mean dB of minus 0.26 dB per year compared to 0.49 dB in the cataract extraction group alone. Also, 66% of patients with hydrous are medication-free at 5 years, a much greater amount of patients medication-free. And they also had reduced risk of reoperation, with 2.8 times less likely to have glaucoma surgery requiring trabeculectomy or tube shunts compared to the cataract surgery group alone. And you can see the trends of MIGS increasing from 2013 to 2018, and the amount of trabeculectomy and glaucoma tube shunts have been decreasing. And MIGS, this is data from the US Iris Registry 2013-2018. They have a very low rate of complications that's often self-limited. The most common things that you can see are corneal edema, hyphema, iridocyclitis, and that's usually self-limited within the first or second week post-operatively treated with steroids and healing. Now, standalone MIGS alone without cataract extraction are much more likely to fail. 25% of eyes required reoperation at 2 years. So it's really important to take the lens out when possible to increase the success rate of MIGS. And also, Black patients with moderate to advanced glaucoma had higher baseline IOPs, are more likely to require secondary surgery after MIGS. So you really want to catch Black patients as early as possible to help improve the success rate of cataract extraction and MIGS. And this recent study showed the association of prolonged use of anti-glaucoma medications with the surgical failure of ab internal microhook trabeculotomy that showed that patients who have been on medications for more than 4.5 years had a lower success rate of ab internal trabeculotomy MIGS. So the longer someone's on medications, the longer you wait, the lower the success rate is. So you want to intervene with this as early as possible to preserve the anatomy of Schlemm's canal, the trabecular meshwork, and the dynamic activity to pump aqueous out of the eye. Now, we also have some data on SLT. This is a study that looked at the effect of prior cataract surgery on long-term outcomes of selective laser trabeculoplasty. And you can see here, you can get as much as a 25 to 26% reduction of intraocular pressure at 30 months out of doing SLT after cataract surgery and MIGS. This one also is after cataract surgery alone. This is a study of 38 patients 12 months out. And you can see here, baseline IOP was 13.51. And at 12 months, IOP decreased to 10.05. And at baseline, the amount of medication is 1.71. And at 12 months, decreased to 0.41, a threefold decrease in medication use. And this is after cataract surgery alone. And now we're starting to see some data of SLT after cataract surgery and MIGS. In this study, the pre-SLT IOP was 15.94, post-LT IOP was 13.71, and the amount of medication was reduced from 1.67 to 0.73, and this was after cataract surgery and iStent. And this is another study that was presented at ASCRS 2021 by Dr. Richard Laroche, looking at about 50 patients who underwent SLT after cataract extraction and iStent. And at 12 months after SLT, the IOP is reduced by about 22.7% in eyes with medications and 24.2% in eyes without medications. And the mean time to adding a medication was about 12 months after SLT. So even after cataract extraction and MIGS, some of these patients will still need additional treatment, and SLT works very well in these patients as well. 22.8% of patients who underwent primary surgery with iStent and phaco underwent SLT. SLT occurred at a mean of about 29 months after primary surgery, and repeat SLT in 7 eyes had a 71.4% success rate. So you could even repeat it in these patients as well. So basically, consider earlier cataract surgery, refractive lensectomy, and MIGS to enhance the success rate of these procedures. The longer the patient's on medical therapy, this reduces his chance of cataract extraction and MIGS. SLT is very effective before and after cataract extraction and eye stents. SLT can reduce both medication burden and IOP after cataract extraction alone and cataract extraction with eye stent. Further studies are needed as we continue to progress in this new MIGS environment as well. Thank you very much.